Tēnā koutou katoa, tōrua ki ngā mate hare hare atura. Kia tatua e Thao ne kia ora, ko Hudson River te awa. Kia ti noho o ki Wellington, ko Stephen Croucher aho. Greetings from Aotearoa, New Zealand. I am Stephen Croucher, the head of School of Communication, Journalism, and Marketing here at Massey University. And we are joining you from the ICA Regional Hub here on Massey's Palmerston North campus. And I'm really happy that we actually have people in person. So this is our, I've lost count, 4th or 5th day together, I believe, which is great. So it's actually felt like really being together and at ICA, working with individuals face to face. So it's really been wonderful. We do hope we can see people in 2022 in Paris face to face at the next in-person ICA. Until then, please enjoy the videos, enjoy the presentations. We've enjoyed quite a few over the past few days. So please log in, comment, watch those, and participate in this online virtual conference. What we're doing this morning is we will have our 9 o'clock panel, Communicating Care and Resiliency, Health Communication. And we'll have a series of short videos presented by our panelists, and then there will be a little bit of time afterwards. Unfortunately, I cannot be here to chair the conversation afterwards as I have another meeting, but one of our panelists will help with a little bit of that moderation, as well as others in the room, I'm sure can all handle that. So I'll turn things over now to Breeze, who will put up our first presentation.
You can play in the order. It's 4 videos.
I'm just going to find
Just let us know, we've been navigating some of the intricacies of Zoom, Facebook, ICA's portal, and when some things seem super easy, sometimes they're always not as easy as they seem. So while we try to prepare a few minutes beforehand, do our best. So doing all we can. So our technical team get things set up.
paper.
Why don't we just do this since the others are live? Why don't we just play the first? Why don't we play the first one that you have queued up? Even if it's not the first one in, if it's Pooja's or whoever's, just play the first one.
Yeah,
please.
you can play. So in the meantime,
Yeah, meanwhile, I'll find it.
we are in the midst of COVID-19 pandemic. When the global leaders gather to discuss about health, the voices of people at the margins are heard. There is little record of the painful choices that people at the margins make in protecting themselves and their families. The study is about one such group, the refugees in New Zealand. The study aims to understand the health and well-being meanings of refugees at the margins during COVID-19 lockdown in New Zealand. A refugee is a person who is outside of his country and is unable to or unwilling to go to his country because of fear of persecution on the reasons such as race, religion, nationality, or membership to a particular group or public opinion. A little bit about the history of refugees in New Zealand. The New Zealand Refugee Quota Program was introduced in 1987. If you look at the history of refugees in New Zealand, the immigration policies were framed to exclude refugees. From 19th century to mid-20th century, the policies were framed to exclude refugees and it preferred people of European origin. So regardless of the growing number of refugees worldwide, the New Zealand refugee quota was kept at 700 to 800 places. New Zealand was hesitant to accept large number of refugees fearing public backlash and insufficiency in integrating them socially and economically. These are the top 10 countries from which the refugees arrive in New Zealand. So once the refugees reach New Zealand shores, they go to the Mangere camp where they are given a 6-week induction program. Later on, they are taken to specific destinations in New Zealand. After that, the resettlement services of refugees is provided by voluntary sector. New Zealand was about to increase the refugee quota by 1,500, but because of COVID-19, it remains uncertain. Refugee health remains at the margins in broader discussions and are a frequently forgotten population in healthcare strategies. Refugee healthcare comprises of many challenges, including language barriers, cultural disparities, substantial trauma, and limited economic resources. Despite its strong humanitarian commitment, the New Zealand government approach to resettlement of refugees is criticized for producing unsatisfactory outcomes for the refugee population. The influx of COVID-19 has pushed us into a rapid adjustment mode, where the national and global responses have left behind refugees at the margins. Families prior to COVID-19 have poorer health and social outcomes in New Zealand. The classification of refugees as victims often masks the politics of the West and the goal of sustaining the existing power structures. By speaking for the refugees, the government, the NGOs, and other organizations are ignoring the voices of refugees. Here, we try to bring forth voices of the refugees by learning from below. Here, I am using a culture-centered approach or CCA. CCA seeks to create dialogic spaces where people at the margins can participate, raise their issues, and give solutions in locally meaningful ways to put forth theories of health and well-being. CCA places communities and the voices at the center of decision-making process based on the idea that communities know the best solutions to the problems identified by them. So listening to the voices serves as points of change, putting the spotlight on the structures that marginalize people at the margins through the language of development, modernization, and participation. This CCA project intends to invert how stories are told and who gets to tell these stories. The participants of this study includes 30 refugees in the Amazon region of New Zealand. Government's one-size-fits-all approach has escalated fear and anxieties among refugee communities. The notion of kindness was embodied in pandemic communication by the New Zealand government. However, the voice of refugees point out that they were left out with less access to support services during the pandemic. The lack of support services was expressed to words like, "We did not have enough support, we did not know where to go to, we did not get the mask anywhere, the council did not help." And during the COVID-19, people were asked to make behavioral changes to protect themselves by following preventive measures such as wearing masks, gloves, and sanitizers. However, the structures remained as such, preventing the people at the margins from accessing these resources. The price of the sanitizers and the gloves were so high for the refugees who were already on a benefit, and there were nothing much they could do. The narratives also point out that the refugees with limited English language proficiency face substantial barriers accessing support services. The challenges included lack of access to readily translated information or difficulties in filling up forms for government support. The patterns of mobility left the refugees more vulnerable as they were limited in their abilities to support one another within communities. The pandemic mechanism of self-reporting and contact tracing created substantial challenges for the refugees, especially for the elderly. Filling up forms and writing down names and addresses was very difficult. These voices point out that it is necessary to consider the mobility and geospatial networks of refugees while implementing lockdown strategies. Even before the pandemic, the healthcare outcomes were predominantly worse among refugee population. The anecdotes of refugees point out that they missed physicians' appointments and routine clinic visits due to the imposed lockdowns. Additionally, healthcare organizations banning patients from having support people or visitors escalated language barriers and anxiety concerning medical treatments among refugee communities. Although online booking and telephonic consultation was made an option, refugees found it hard to access the daily services and found the process prohibitive. Furthermore, online providers of health were not able to provide inclusive or culturally responsive care. The chronicles of refugees show that they went through long and stressful waiting periods while trying to access health care. So overall, the non-existence of voices of refugees in the policymaking spheres establishes the marginalization, and hence there is a need to foster participatory spaces for listening to the voices of the refugees at the margins. an approach to pandemic communication like in New Zealand, touted as an exemplar of effective pandemic communication, can be inadequate to address the needs of the refugees at the margins. So contrary to the dominant pandemic communication view that health is an individual accountability, where every being is accountable for his or her health and well-being, the narratives of the refugees articulated health in the language of support and relationships within communities. There is a need to create entry points to listen to the voices of the refugees and introduce them to discursive frameworks that have systematically erased them through top-down models. Thank you.
Thank you, Pooja, for your beautiful presentation on refugee health. And I think for your data collection, you are utilizing culture center approach. And would you please tell something how you collect the experiences of refugees in Aotearoa, New Zealand?
Yeah. So for this research project, the participants were from the Palmerston North region of New Zealand. So Palmerston North region has high number of refugee population. So we conducted this interviews during COVID and some way over the phone, and post-COVID, 30 interviews were conducted among refugee population in New Zealand. So most of them were females. So we have participants from Afghanistan, from Nepal, and like majority of the participants from Afghanistan, especially, were single mothers who struggled during the COVID-19 period. So even though the notion, like the pandemic communication in New Zealand was embodied in, the concept of care and kindness, the voices of the refugees point out that, they were left out during COVID-19, especially they didn't have access to healthcare services. Usually community members accompany them to help them, especially the elderly. They don't know how to read and write, so their children accompany them, but that was limited. Support persons weren't allowed in healthcare institutions, so they couldn't access healthcare services, and even the supermarkets didn't allow children in. So for the single mothers, I have a participant who had 5 children. She had 5 children, and she had to leave her children at her home to get food for the family. So it was a troublesome period for most of the participants.
And I'd like to know another thing. During lockdown, everything was closed. So how did you collect the interview, or how did you conduct your interview during the lockdown period?
Yeah, so we had community researchers helping us. So they were in constant touch with the people in the community. So they had varied needs like food, medicines. In fact, we formed an online Facebook page. It was Manwatu Information Hub, where community members came together to support each other. And one of our participants was in need of medicine. She wanted insulin, and she couldn't access it from the healthcare service that she was into. She went there several times, but she couldn't meet the GP. She wasn't aware that she couldn't meet the GP during that time. She went there 2 to 3 times, but she couldn't access them. So then I had to seek the support of community members who came forward to support her with medicines, but that wasn't the medicine that she actually needed. Then I had to ring up the healthcare center and to ask for repeat prescriptions and to manage that.
Yeah, thank you very much. Yesterday we were also discussing that relationship between researcher and the activist.
Yeah.
So I think though you are a researcher, you are also helping the community also during the lockdown period.
Yeah.
Thank you very much. Then we would like to the next presentation. Please play the next presentation. Communicating care, COVID-19 experiences in the Philippines. We'd like to observe that presentation now. Please.
Mabuhay. Today we are sharing with you our presentation titled Communicating Care, COVID-19 Experience in the Philippines. I'm Jayan Risto, and with me are Miss Jayan Stephanie Gavan and Professor Elena E. Pernia and the University of the Philippines.
Recent developments in the COVID-19 situation in the Philippines show an alarming increase in the number of confirmed cases across the country, with the numbers hitting up to more than 840,000, the highest since the onset of the pandemic. This is despite the fact that we have been in the longest lockdown since early 2020. This has caused economic devastation that the public health crisis has given birth to a humanitarian and communication crisis. Restrictions in mobility, closure of schools, establishments, and businesses has caused millions to lose their jobs, and widespread unemployment caused stress for individuals and families across the country. The public then turned to the media to gather information about the virus and to connect with their loved ones. Social media, in particular, became a tool to gather information and to connect and show support to the larger community. However, it also harrowed fear and confusion, with misinformation undermining the people's trust to scientific and evidence-based information.
The objectives of this research include, first, to determine the content and sentiments expressed in COVID-19 related social media posts, and second, to assess COVID-19 literacy among the public. Utilizing a mixed method approach, social and emotional listening, and online panel and telephone survey were used in the primary data collection methods. Respondents of the study are Filipino adults ages 18 and above across socioeconomic sectors.
Preliminary results of the social and emotional listening revealed that the primary emotions conveyed by the Filipinos online include anger and hate, sparked by the government's inconsistent report and inadequate response to the COVID-19 pandemic. Fear, anxiety, and panic also dominate the public sentiments, triggered by the continuous increase in the number of daily cases. The agitated public panic bought food and supplies, including alcohol, tissue papers, and face masks.
With the public confined at home, a sentiment of boredom was expressed, which resulted to heavy reliance with media use, including social media and video streaming sites. Despite the public's growing anxiety, there are still sentiments of hopefulness and optimism, particularly with them looking forward to seeing their loved ones again. People who are able to continue with work following a flexible arrangement express their gratitude.
Among the dominant sentiments as well is empathy shown through various calls for support and donation, likened to the Filipino virtue of bayanihan, or the practice of helping one another. This is a virtual response by the public to aid our countrymen in need and to show support to our medical frontliners by raising funds for medical equipments and other needs.
These figures show how sentiments and emotions peaked and were continuously expressed from early 2020 to 2021. Fear, anxiety, and panic is an undercurrent emotion throughout the period, with considerable surges in sentiments of anger and hate, of empathy, and calls for donation from time to time. Increase in emotions related to the COVID-19 vaccination surfaced towards the third and fourth quarter, where conversations on clinical trials and vaccinations emerged.
The preliminary results of the telephone survey indicates that COVID-19 literacy is low across all sex, age group, and region. Majority have reported little to no knowledge on COVID-19, transmission of the virus, and on prevention against the disease.
Despite low knowledge scores, the respondents expressed a generally optimistic view on the country's chances of overcoming the pandemic, and majority perceive themselves as key individuals in preventing the spread of the virus in their respective communities. Expressions of worry when visiting public places and willingness to undergo home quarantine are expressed by almost half the respondents. Majority agree that employees returning to work should undergo the necessary tests to ensure they are virus-free.
Very few of the respondents reported to have acquired other non-required vaccines such as flu and pneumonia shots in the family. Moreover, majority of the respondents are not willing to get immunized against COVID-19.
The top three information sources when it comes to COVID-19 information are broadcast media, social media, and interpersonal sources. Results further show that television is still the main medium used for delivering, sourcing, inquiring, and sharing COVID-19 information.
This shows that there is a gap in communication between the public, the government, and the health institutions. Low knowledge levels and emotion of anger, hate, fear, anxiety, and panic remain dominant as the country continues to grapple with the effects of the pandemic. With the public heavily relying on various information sources for their communication needs, the challenge to effectively educate the public by allaying the fears and anxieties remain. Communication strategies must consider individual and community sensitivities while maintaining the relatability and comprehensiveness of the message. As the public health crisis transforms into a multifaceted social problem, using communication as a tool to inform the public and to elucidate their participation is important.
As a recommendation, an evidence-based and culturally appropriate communication plan focused on building vaccine confidence and instilling healthy behaviors and practices will be developed. Tapping into the Filipino values of familial care and love, and the virtue of bayanihan, which extends to care for the community as a framework for messages, communication strategies for science and evidence-based information will be crafted. Moreover, an omni-channel approach will be utilized to enhance audience reach and assuage misinformation. Thank you, and good day.
Next one.
Yeah, you can play the next one. Then we will discuss after completion of all the presentation, and then also ask the audience if they have any questions or not. Yeah, next presentation. Right?
Yeah.
SARS-CoV-2 was first announced by the World Health Organization on December 31st, 2019, and it was only on March 2nd, 2020 that we had the first 2 infected people in Portugal. We lived under an emergency state in Portugal from March 18th to May 2nd, 2020, and during that period the country was confined, and this confinement was always reported by news media. And so news media assumed citizens' behavior guidance because they became a means to fighting COVID-19 and helping people stay home. Even though this state of emergency will certainly be a mark in the history of Portuguese journalism, the truth is that Portugal is not an isolated case. Indeed, several authors recognize the importance of health communication and health literacy in fighting COVID-19. In public health crises, news media are important actors in the promotion of health and prevention of disease, and they can have a central role in behavior change. Health literacy, achieved also through effective health communication, is fundamental in social transformation. The sudden appearance of SARS-CoV-2 has highlighted the importance of health communication and health literacy within the context of infectious diseases. We know that news media play a central role in promoting communication about health, and they have the potential to change knowledge, attitudes, and to some extent behavior. The invisible nature of pandemics dictates an important role for media as the eye of the public. Also, the role of news media in public opinion is well documented in the literature, namely by the agenda-setting theory by McCombs and Shaw. By defining themes, categories, and hierarchies, the media tell people what to think, how to think, and which issues to prioritize. Besides describing the effects media messages may have on people, the research by McCombs and Shaw shows that the news media may crystallize dominant opinions, establish priorities, and set the importance of. The goal of this research was to assess the impact of COVID-19 pandemic in Portuguese journalism through journalism perceptions. This is part of a wider study that aims to analyze the Portuguese media coverage of COVID-19. And in order to do so, we applied an online questionnaire survey through Lime Survey platform. Data collection was from May 11th to May 29th, 2020, and the period of analysis from March 18th to March the 2nd, which corresponds to the state of emergency. As for case selection, we selected all national news media outlets, radio, online, written press, and TV, which were stratified through mutually exclusive categories. journalists, health and science journalists, editors and coordinators, and TV news coordinators. As for the elements of analysis, we wanted to understand the impact of telework, organization of newsrooms, concerns with health literacy, difficulties experienced in selecting information, concerns to guide citizens towards COVID-19 preventive behaviors, journalists' perception of false information, and the strategies they use to neutralize misinformation, and the most valid characteristics in a moment of choice of specialized sources. Our corpus of analysis has 200 questionnaire surveys. Survey results indicate that 92.2% of journalists assumed a continuous concern with behavior guidance, which is something new in the country's democracy since 1972. So we can see that on an editorial level, besides conveying relevant information, journalists had a concern with behavior guidance towards prevention and treatment of COVID-19. They revealed a true concern with informing people about the pandemic's evolution and with helping them stay home and adopt preventive behaviors such as respecting social distancing, avoid engaging in gatherings, and wearing a mask. If your answer was yes, behavior guidance was achieved through, and journalists used a lot of tools to achieve behavior guidance, news and private texts, but also infographics, explanatory boxes, and specific pieces of news, and other kinds of tools that they used as allies in their news pieces. It is true that health journalism is perhaps the beat journalism that gives more room to the promotion of literacy, and during the pandemic this was notorious in the Portuguese press. Indeed, health literacy was always present in news texts, both through news pieces and through opinion. During a public health crisis, news media are important actors in the promotion of health and prevention of disease. The Portuguese news media promoted health literacy through the use of several tools. And besides their concern with giving useful information about the virus, journalists recognized they were worried with helping people navigate through complex public health themes. Also, the news media promoted to the public media space people that became sources because of their expertise and not because of their political or symbolic power within society. So besides their concern with giving useful information about the virus, they recognized they were worried with health literacy aspects, and the journalists' work reflects a concern with the promotion of health literacy achieved through news pieces, but also infographics, questions and answers, or explanatory boxes. Journalism was therefore an essential means to help people stay home. It was a central axis of democracy and not just a business, and journalists assumed a true public service mission. The Portuguese case is often pointed out as an example in which a severe lockdown decreased the number of deaths and infected people, and they showed their commitment to the public and fulfilled their role in the first months of this health crisis. Thus, the entities that define health policy must integrate journalists as partners in the strategy to combat the COVID-19 pandemic. And this public service mission assumed by journalists was an important means for citizens to quickly adhere to confinement. Thank you all so much.
Hello everyone, welcome to our presentation today. My name is Wan Wei and I'm from Rutgers University. I'm here on behalf of me and also my co-author Surabhi Sahai from Penn State Abington. In the past year, we have all experienced tremendous changes in terms of the way that we communicate. For nurses, the situation is even more complicated since they already face a lot of work stressors before the pandemic. Since the onset of the pandemic, nurses have to work for long hours, work with limited resources, and cope with risk and uncertainty revolving around the pandemic. Among all these new sources of stress, changes in family communication patterns became one of nurses' top concerns. In this paper, we examine nurses' coping strategies to deal with the changes in family communication and to cope with communication-related challenges. There are several lines of research that are relevant to the current project. First of all, researchers have a consensus that nursing is a particularly stress-inducing profession. Nurses have to face a lot of difficulties in their work environment on a daily basis. This makes getting sufficient social support very crucial for these nurses, and family, as we all know, is an important source of social support. It helps people persevere through a difficult time. In this paper, we examine how family support has changed for nurses during this pandemic and how do nurses cope with these changes. We draw on two prominent theories that contribute to work-family interaction. First of all, we draw on work-family boundary theory by Clark. We also draw heavily on the boundary theory developed by Ashforth et al. Another relevant topic to our paper is spillover and crossover effects. These are negative psychological effects that may occur when people are managing boundaries between work and family. To better understand nurses' experiences of family communication during COVID-19, we have developed two research questions. First of all, how have work-family boundaries changed for nurses during COVID-19? And second, how do nurses deal with changes and effects communicatively? To understand these research questions, we have conducted 24 semi-structured interviews of frontline nurses, which accumulated to 19.5 hours of data, and the method used in this paper is thematic content analysis. In response to research question number 1, how have work-family boundaries changed for nurses during COVID-19? We have found that exchange of information and concerns between the two boundaries, work and family, intensified during this time, which has caused negative emotional experiences for nurses. Some of these negative emotional experiences include fatigue, frustration, fear, and guilt. For example, here we have a quote from our data. It was extremely fatiguing, almost like I was working even at home. I had haunting images of my patients, and I could not bear another person, let alone a loved one, go through it. I was obsessed with sanitizing my home. There was no break. This quote shows how permeable the boundaries between work and family have become since the pandemic. Also, in response to research question 1, we have found that COVID-19 presented the nurses with unique concerns at work that they had not dealt before. Here we have a quote from the data. It gets especially difficult on days when I know many at work won't make it. I will go back to an empty bed. When I was fixing dinner for my kids, that is all I was thinking about, and almost destroyed my food. Nurses had unique work concerns during the pandemic that they have never dealt before, such as loss of patients, uncertainty about the disease, concerns about contagiousness and risks. And as we can see in this quote, sometimes nurses brought these concerns home, which had disrupted their interactions with their family. In response to research question number 2, how do nurses communicatively manage spillover and crossover effects during COVID-19? We have found that nurses had adopted 2 sets of practices. The first set of practices were related to physical and temporal transition and at-home implementation and other tangible practices. For example, here we have a quote from the data. It's a 40-minute or so drive, and I would constantly think about the protocols that we followed at work and how I could use that at home. Here, the nurse was making use of her drive home to strategically plan for what she had to do when she get home. So nurses had been using this time to plan for physical and temporal transition from work to home. Nurses may also adopt communicative practices to deal with spillover and crossover effects. For example, some of them may distort information. Some of them may avoid the conversation altogether. So here we have another quote from the nurses. I don't usually go into the details, especially on a bad day. That shows how the nurses minimize the difficulties that they had experienced on a daily basis. To conclude, our work on nurses' experiences during COVID-19 had expanded our understanding around work and family separation of domains. It added to our understanding of sub-boundaries, which were not clearly discussed in the boundary theories. And also, it has enhanced our understanding of permeability between the two different domains, work and family. Additionally, the results of our study confirm that effective communication and social support can help reduce spillover and crossover effects. Our study also had some practical implications. Overall, it is very important for nurses and other frontline health workers to get sufficient social support from different sources. Organizations should develop better strategic plan to offer the much needed support for these nurses. Thank you.
Thank you all for your beautiful presentation. In first presentation, we observed the refugee scenario, experiences of refugees during COVID-19. And second on, that is the study of Philippines. We observed that there are some happenings during COVID-19. People are very fear and they are agitated, and agitating people by various items from the shops. And during lockdown, during COVID-19 lockdown, we also had the news that there is a shortage of toilet paper even in the developed country like Australia. So the people try to hoarding something, so they cannot think how they will purchase during the lockdown period, and that's why they hoarding the items. So fear and anxiety it was very common during the lockdown period. And next presentation, health behavior guidance, that is Portugal. That is what the journalism can do, what the journalists can do during the lockdown period, and how the public think about the pandemic and how they have to behave. That is mainly communicated through the media. And I would like to say something about my experience when the COVID-19 started in 2020, starting on that 2020. At the time, I have been working in Bangladesh television, that is media. And during that time, it's my experience, we do not even think this disease can be spread throughout the world. At first, we think that it started from Wuhan and it would be settled down through the Wuhan. And at that time, we even do not make any importance of the COVID-19. So we just give the news, some death occurred due to COVID-19 in China, etc. But we even do not think it may be spread throughout the world and it may become a pandemic, like many people will die through this disease. But journalists can do a beautiful thing. Journalists can inform the public how they have to behave during lockdown, how they can communicate with each other, and how they can stay in the home. And this type of information are mainly communicated through the media, and journalism helps a lot to educate the public during the COVID-19 period. And the third presentation was on about the nurses, and I would like to say something, Pooja, about the nursing during COVID-19.
So the final presentation we had was about work-family balance during COVID-19. So during COVID-19, we went to a rapid adjustment mode where, the sanctioned power to care was used to silence the voices of the communities. And when the global leaders gathered to discuss about health, the frontline workers, the nurses, they were never invited to the table to discuss about COVID-19 and the aftermaths of that. So the last presentation was about how COVID-19 affected the family work balance among nurses. So the study shows that the unique experiences of nurses at work, like loss of patience, concerns about risk, high fatigue, and guilt, etc. And the nurses brought these concerns home, which affected the relationships in the families. And they didn't have enough sources to ventilate out their concerns, or they didn't have a support mechanism to talk back or to express their concerns. So the study suggests that there is a need to have family social support for the healthline workers like nurses. So I'd like to open the floor for further questions.
So I just want to make a comment
Sure.
over here. Like, since yesterday, we've been on like several panels to talk about like the influence of COVID-19, and I have a feeling that somehow COVID-19 reveals the ugly truth of our societies right now. So I think for now, the most vulnerable people suffering from the COVID-19 are refugees, like people with no identity, like Rohingya.
Rohingya refugees, yeah.
So I feel really bad. I just hope that the policy makers can hear, listen to our like research studies, because like we are just commoners, we are like scientists. We just do the research. We listen to the voice of the refugees, of the people, of the nurses, frontline workers, etc. But we don't have we don't have the power to do anything to support our study. So our support is just like to listen to them, and like through our anonymous research data collection. So we just hope that the policymakers could listen to us. That's just my comment about this one.
Thanks, Thao, for a beautiful comment. Yeah, as a researcher, we can only give some idea, right? We can put some idea, but it's not our duty to implement that idea. That is the policymaker who should take the idea, and that should be implemented for the betterment of the people. So we only proposing the idea, right? And the policymaker should implement it, so that the people at the margins of the margins, or the refugee people, so that their life maybe somewhat they can take a better life.
And I think that COVID-19 somehow has flipped the theories, the constructs, the concepts, like everything in our research. So now I've been doing research on COVID-19 and prejudice as well. So like the data shows that it's totally different from what we have done before. Because like it's not just about the health crisis, it's just like economic crisis as well. Like people all around the world are suffering from COVID-19. So that's why now they reflect their responses really, really differently. So I think further research should be conducted more.
Any questions online?
No, not that I can see as of now.
Yesterday, on discussion, we also observed that what is the relationship between research science and the activism. So some researchers can also involve themselves into activities also. That may be helpful for the general people. So yesterday we observed what may be the relationship between activism and the research community.
And I really like the presentation of about the health behavioral guidance, how Portuguese journalists took care of people during the COVID-19. So is really beautiful because like not many countries we have freedom of speech
Yeah.
on journalism. So it's super helpful, especially in this crisis, like because the journalists can help people to raise their voice.
Yeah.
But some countries no, it's forbidden.
Yeah.
Like they are controlled by the
State,
authorities.
yeah.
Yeah.
And I just have one question about your presentation.
Yeah.
So speaking of the refugees from in New Zealand right now, so when you did your interviews, so what do they really need right now from the government support?
Yes. So they have identified various issues that has been there like pre-COVID as well. So they had difficulties in accessing healthcare support, especially in this region. Interpreters aren't there whenever they needed to go to hospitals. So what usually the women do or the elderly do is that they take their children with them, so they have to miss their school classes to be with the mothers, so that they can explain what the mother is saying to the GP. So they have concerns regarding healthcare services, and some of them are available like online, like on-call interpreters, but they are not available in like all languages, and you won't get them online when they actually needed it. So another was difficulty in mobility during COVID-19. So the community people are the ones supporting each other. So especially, the COVID tracing mechanism. So whenever they have to go to the supermarkets, they have to write down their names and numbers. So especially for people with language difficulties, they couldn't understand what the form is for, what the instructions are, the markers and the steps. So that created anxieties and fear among the participants. And one of the participants was asked down by the police to stop, but he didn't understand that he had to stop. So that were the kind of difficulties in mobility. And another challenge, like the participant noted, that was pre-COVID as well, which escalated during COVID times, was concerns regarding housing. So the recent refugees are, put in private housing. So the benefit that they receive, goes to the rent, and it is not sufficient enough to feed their families as well. So some of the participants, raise their concerns that their children, they had to drop out from their schools because they wanted to support their families because the benefit wasn't enough. So they had to drop out of their school, and currently they are working in meat industry in fielding. So they have lost their, their entire lives, their career itself, just so that they can support their families. So the notion of kindness and care that we see in New Zealand, it's just at the peripheral level, and we don't see the voices of people at the margins. So what are their experiences and things like that?
Yeah, I really agree with you. Can you imagine that, like for now, New Zealand is pretty safe. When we speak of when it's related to COVID-19, but refugees are still there, all around the world. And now even like refugees in New Zealand are still like have some problems, challenges related to COVID-19 and other things like that. So can you imagine like how refugees around the world are living right now? So I just wanted to speak, speaking of the humanitarian, sorry. So I feel really bad for those people who have no identity right now. How can they live? So what's their future? Especially for children.
Yes, yeah. I think the structural, there are different structural challenges like in New Zealand. So one of the key pillars of refugee integration in New Zealand is participation. Even though it is written down in documents, it does not, in practice. So they don't listen to the voices, even though participation is one of the central pillars of refugee integration. So it was clearly evident during COVID-19. So one of the participants said this was her experiences, in New Zealand that's not concerned with COVID-19. So she wanted to study further. She wanted to do her civil engineering, but the immigration kind of told her that she cannot move out from Palmerston North region because she wanted to go down South Island and study. And she had applied for a family visa so that she can bring her brother in. So the immigration officers told her that if she moves out of Palmerston North, her brother's, the visa processing would be stalled. So she had to, stay in Palmerston North and take another course. So she has to give up her dreams so that because of the existing structures and immigration policies that hinder her, the
The
refugees
future
progress.
development, yeah.
So I think that in theory, the policy looks really beautiful.
Yeah.
But
in practice, yeah.
No,
Yeah.
it's not. So I think for now, so the policymakers should go out there to meet people, to listen to their problems, their concerns right now, and then they can better their policies to make it more practical.
Yeah.
True.
Check.
Any question?
Comments or anything online? Just give me a second. No. No comments.
So we'll wrap it up for the day and we'll come for our next presentation, which is at
What is that?
11.
At 11?
Yeah.
Thao will be
Thank you
presenting.
so much.
Okay, thank you all. We'll meet again at 11 and Thao will present at the time. Okay.
Thank you for
Okay,
joining
thank you.
us. And for those who are from tuning in later on, see you at 11. Thank you.
See you at 11. Thank you.